open the floor for discussion. I'm happy to ask the first question and take the chair's prerogative. Professor Schultz, can I ask you a question? Can I ask you a question? With the training program that we've started and the students have got trained, how do you plan to maintain their professionalism and their ability to continue to be a midwife once in the community? So we train them and send them there. How do we maintain them from then on?
Michelle? Sorry. So each year they have to prove that they're competent as a midwife. So they have points that they have to collect by attending conferences or things like that. So they keep their registration up. It's very, very strict. So,
because in rural areas it's very difficult to maintain your midwifery credentialing because you need to do 40-odd births or something.
Initially, yeah. And then if you don't maintain those births in the year, you need to say why or what educational background have you done to maintain that, yeah.
Thank you.
Kind of got a twofold question actually, just looking at some of the trends across all of the presenters, a bit of an carry on from this morning, but I just wanted to know from other health professional groups, I'm from nursing background, Karen Taylor, I'm a community nurse educator in Metro South, and I've kind of got a sense of a change in, or a trend where more and more is being put into the curriculum in terms of clinical placement experience that's required. So the clinical placements, we're looking at trying to get longer placements for students that are clinically relevant, but also in sort of specialty areas like spinal, Indigenous health and so on. And are our curriculums getting so big trying to fit in both academic and clinical programs? And how do we manage that, particularly in undergrad period, with, first of all, loading up the program and the potential for clinical supervisor burnout, which is a big problem that I find in my area, where in community health, very like regional and rural, it seems silly because we're sitting in suburbia, but our staff are in tiny teams and they have students back to back to back to back. They end up kind of going, we don't want any more. So I just was interested to know, is there a trend for trying to put more in undergrad programs, or are we looking at being innovative in postgrad and saying, well, perhaps leave it until you've finished and then go to some of those specialty areas to get your experience? I don't know what people think, and I'm interested in what the panel... Sorry, it's a massive question.
It might be good to have someone from JCU comment in terms of placement, but we certainly appreciate, the longer placement. So the seven weeks for OT in third year and then 10 weeks in fourth year. Students get to choose where to go, so they haven't necessarily learnt anything about spinal cord injury prior to coming. That's our responsibility when they get here and get to us. And if we have 7 weeks, then we've got some time and we have a program where we educate them about spinal cord injury. And I take your point. I think that we've asked a lot of our supervisors this year, and we've already decided no first year OT students next year. It was too much. So I think that's going to put pressure on JCU, and maybe they need to look at a model as to how beneficial it is to have a 1 week observational, which is what they do have. And all their first year students have to do it, and we're pulling out of that. But we give them a lot of placements in third and fourth year because of the impact it has on the team. So that may be an answer from JCU about revisiting those placements.
I was going to get maybe Sonia or someone to answer the placement questions, but if I could just make a comment, I mean, my point was around, student numbers are growing, and so, it just means more places that need to occur. Well, we need to find more places, for students out there. But the other thing is, just from the work that we've done here, is just the value and the length of time that students spend in a service, and basically the students, they go and spend one day or half a day there. It doesn't really give it any value for organisations when they put the effort in, and this is the sort of feedback we're getting. We put the effort in to mentor and support students while they're in placements, but half a day or one day is really nothing. But not realising that it's all part of an overall sort of rotation that students do. Not sure if this answers your question, but I think just going back to whether placements have increased, maybe Sonia might be able to answer. Or
We'll come back.
sorry, Sonia Van Brennan, school manager for.
Yeah, okay, so I'm from JCU as well, and I'm from the medicine side, so I'll declare that up front. We have the luxury of a 6-year course, and medicine has always been heavily steeped in clinical placement and clinical education. So in medicine we don't have the same kinds of pressures as some of the other schools, in other disciplines, in terms of trying to expand their clinical placement component, because it's always been there and we've got 6 years to do it. On the other hand, we focus a lot on starting early and doing lots of it across the 6 years. So we don't wait until they're in their later years before they've seen a live patient. And to that extent, we're asking our clinical placement providers to take the baby ones as well. And who are less useful. And so you have to develop a relationship with the health service provider where they can see the benefit of having the students, in first year, in second year, in fourth year, in sixth year, doing different things and having different learning outcomes. And sometimes that is difficult in terms of, it's okay, we can get places for the year 6 is easy, but trying to encourage people to also take the younger ones is a challenge. So what Donald's saying about the numbers for medicine is right. Our pressure is the extra numbers, not so much additional clinical placement in the course. And I understand from especially our allied health colleagues, that they're coming from a different framework where they're trying to get as much clinical exposure into a much shorter course. So does that help?
I just wanted to add a comment. I'm from nursing, midwifery and paramedicine, so I understand what you're saying. I mean, we have the pressure of finding student placements across all our disciplines, and I think we probably place students almost every day of the year. And so it is a challenge, and then there is a real risk of burning out the people who are working with your students in placements. And I guess when we're thinking about the project that we're doing, I guess that's one of our things on our to-do list for the future, is to find better ways to support the people who are supervising our students when they're away from base and away, not as connected to us on campus, to find better ways to support them.
It's just a curiosity question with the medical student placements. Over the year with the placements in our area, we've really looked at multidisciplinary placements. So yes, being placed in general practice, but also doing time in the hospital, doing time with the Aboriginal community and QAS and community nursing. And so student doctors are not always working with other doctors. And it's a follow-up comment on your going out with the health worker. And we've found that the students are actually really positive about working with those other disciplines. And I was just wondering if you were finding the same thing. Yeah,
no, certainly that's the case. And with the consultations that we've done, the focus group, we've included, health workers and basically all staff that work, within the services that have, the invitation that went out was to anyone that has an interaction with a student to come to, the focus group workshop. So health workers, the admin staff, and Yeah, we had 24 in one group, so you know it was bigger than a focus group. But yeah, so people recognise their role too, and but it was we just needed to formalise that and agree on that because at the moment, the students and supervisors, the doctor that's in the service there is a central point. They coordinate when the student comes, the student spends time, with the doctor, but not realising, the importance of them being placed with the other, staff, other health professionals that work in the organisation too. But in saying that, some places that work, really good. I think Mullingu is a good example, where they really distribute, the load with all the staff that are involved there. But we just need to formalise that and communicate that a bit better about sharing that role within the services. Some students, get to cook damper.
Thank you. I just wanted to make a comment then ask a question. I think the challenge in each of our disciplines and the way we run the curriculums is not just the placement, but how we join them up. So, the 2-week placement with community health and the 4-week with this and the 8-week with that or whatever, I think we really need to challenge how they're allocated and challenge ourselves how they're allocated and say, is it possible to join these up? And I know we broker across a whole lot of disciplines in universities and by saying this is what we can offer free or heavily subsidised accommodation, these sorts of placements, but we want them for longer. In a constrained placement time, people are starting to respond to that, and I think it is really important that because it does impact on the students' experience. They get better at it, but we help prevent the supervisor burnout. I'm really interested in what was the unexpected thing you learnt? Like what in your project, what came up you didn't expect? I know there'd be a list.
I'm just trying to think which one. I don't know, not so much unexpected outcomes. Just looking at Denise, nothing really unexpected.
No, I think one of the biggest challenges. Sorry, I think one of the biggest challenges was probably in terms of Michelle's role and actually providing that Indigenous academic support for that role and actually finding Michelle and keeping her. So, I think that's, exactly. Yeah.
Out of every project comes something that,
We didn't expect it would be quite as hard as that. I think we thought it would be, and we were able to get somebody else for a little while, and then they were recruited to one of the hospitals. So I think that in order to provide the enhancement, it was almost like we needed to do the project to get the people we needed. So I think that in those early stages, you're trying to create that reality, and that was a real challenge, I think.
Not so much unexpected, but a very pleasing outcome that I didn't sort of think was the real strengthening of the relationships. And I was thinking back to the presentation, this morning, the combined one, we're talking about across silos. And a real strength has been bringing a group together across some of those, from the Indigenous support unit, from the school, from the clinical placement setting, the students. And I think that strengthening of that relationship that way has been really, really important. Not so much unexpected if it's something that wasn't on the surface of our thinking necessarily, and that will be the key to us moving forward, I think.
I think the same sort of stuff too, the whole communication. And I think for us, going out and running focus groups and the purpose of gathering information, we end up facilitating the conversation around, what can be done, the sort of immediate things that can be done, within a workplace and between the workplace and the university. So, we weren't expecting to have those sort of things, immediate outcomes there. And I think it does, highlight that, going back to sort of the simple conversations that need to take place and need to be continuing to make sure that we, address the sort of the issues, as they come up, but making sure we're a bit more, proactive in that too.
I think one of the unexpected outcomes for us, and it probably relates more to the rural and remote rather than Indigenous, but what we did was we've set up an interprofessional clinic in Townsville, which I'm hoping with further funding we can do through telehealth right across North and Far North Queensland. But our clients got to choose a one-stop shop to come and see, and they got a choice of seeing nurse, physiotherapist, exercise physiotherapist, doctor, dietitian and OT. And so it was driven, we sent the information out, we sent the model out, and our clients got to choose. And then what I asked the practitioners, they had to donate an hour at the end of the clinic to a case presentation where we all got together, and 5 minutes, everyone had 5 minutes to talk about, I saw Jill Morrison and blah, 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 and then our clients knew that conversation was happening. And what our student did, our student whoever the student was on placement, had to minute that meeting and develop an action plan for each client. And then that action plan was mailed out to the client saying, you saw all these people today and we all talked about you, and here's the action plan that you may want to follow up, you may not, but bring it next month and let's have a conversation about it. And the unexpected bit was when I sat in on the case presentations was not only that the physio learnt what the dietitian did and the medical students, we had all the students who attended the clinic all sat in on the case presentations. We had this enormous full room and we put on lunch. So it was lunch, let's all talk. But what was unexpected was we knew the clients really well. They told different bits of information that the OTs never knew about them to the dietitian, who they may have never met, or to the exercise physiologist. And so everyone in the room got a much better picture. And of course, written consent had been given, obviously, about who was in the room and the conversations. But it was something that people were surprised about, that you would assume that someone would give similar information. And in fact, some things were hidden for years, but someone else with a different perspective, that person chose to tell different information. And I found that quite unexpected. And I guess it's about holistic practice and a one-stop shop. Yeah.
In the interest of time, we have to take the last question.
I just wanted to ask the panel. We hear about health professionals talking about how students are a burden, and I wonder where this comes from. Like, how has this evolved? And because it wasn't really amongst our professions, originally. So who takes responsibility for that? And so do you have any suggestions as to how, as teachers, as professionals, how we can change that and make it that students can actually be fantastic and they can actually help you. They're not always a burden. How do we change that?
A couple of things from this morning, I suppose. Motivation is one. Certainly that's something we got from Dom. So if we've got supervisors who are motivated people find a way around for hours, and that extra 30% of time you've got to find. And I guess that sense of responsibility, to me, motivation, what I see in the clinical staff I employ is high motivation and a high level of responsibility and an interest in making sure more people know about their particular area. So I think it's about that drive. you know, we're all a burden at some point. I'm sure, you know, the fortnightly team meetings I run, they're certainly a burden to your time. So I think it's about attitude, isn't it? And I don't know, that starts and that responsibility lies with all of us.
To add to that, I think, again, it's the power of the relationship. It's the relationship you have with those people who are providing those clinical placements for your students. And if that relationship is strong and there's, you know, a strong link between then situations that can be burdensome, you know, where there's difficulties, etc., and that can tend to colour the whole placement experience, can be dealt with really quickly, you know, and effectively. And that creates a more positive, I think, more positive and collaborative sort of partnership environment.
Yep, comment is welcome, no problem.
I mean, as an employer and someone who runs hospitals, basically, it's good for the hospital. You know, if people don't want to teach, I don't want them at the hospital. And that's the environment you have to create. And, you know, yeah, if you know, we're all professionals. If you're not interested in teaching, you can go out and practice by yourself. But you shouldn't be in an institution that considers itself a high-level tertiary institution or anyone. I tell them. Yeah, and that's why you have to engage. Well, you should engage the people who run the institutions, facilities, like we have here. You know, if a facility has an environment of teaching, then it drives people to teach, and they enjoy it.
I think students take the best history. I'll end it at that. Thank you very much.